Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I am Nicola Brook and I am the solicitor at BJC with day-to-day responsibility for managing our work on the COVID inquiry on behalf of the COVID Bereaved Families for Justice UK. I'm here today with my co-host Lorelei King, who is a member of the group, having sadly lost her husband to COVID. Joining us both today to discuss the hearing this week is Enda McGarrity. He is a solicitor from P.A Duffy and is instructed by the Northern Ireland COVID Bereaved, and he is taking the lead on Module 3. Welcome, Enda.
Thanks very much, Nicola. It's great to be back.
Really nice to see you back, Enda. You always have some incredibly insightful things to say. It was an incredible week. There were a lot of themes, this overall theme of mental health of health workers and the absolutely horrific conditions they were working on. And there were some high spots with witnesses like Sir Michael McBride, Chris Whitty, and perhaps most memorably, Professor Kevin Fong. But I wonder first if we could touch on a couple of the other witnesses. I was really interested to hear Tracy Nichols, the chief executive of the College of Paramedics, give her testimony, learning of the challenges to paramedics and ambulance workers. Nicola, you said, I think, that she was talking great common sense.
Yes, I think I'm going to rename Tracy Nichols Captain Common Sense. Just everything she said, it just made so much sense. But it also kind of reinforced why paramedics are overlooked, things that are so obvious to her and anyone working in that environment. For me, I hadn't thought about either. And what she was trying to get across was all the guidance about IPC and PPE, that's all about people who are working in a hospital, really, whereas her crews are stuck in an ambulance, this tiny little space that has no ventilation. They can't even open a window in the back. They are providing up-close care, or even outside of the ambulance, they're having to go into a patient's home where they don't know if they're walking into one patient or someone who lives in a full household. And so it's not just the risk that one patient presents, but it's everybody else in that house that they have to come into contact with. Also, the fact that that patient may have COVID and be asymptomatic. So even if they're saying, I'm fine, I don't have COVID, but please come and help my husband who's had a heart attack, they have absolutely no awareness of what they are walking into. And yet they are being told that the lowest level of PPE will keep them safe. And she was trying to get across that our members are healthcare professionals. They knew that didn't make any sense. And yet day after day, they are going out, putting their own lives at risk, trying to care for people in the best way they can, whilst the people who are responsible for keeping them safe are seemingly sending them out to risk their own lives.
Yes, she said that the workers had said they felt unsafe, and the guidance they were in contrast with what the IPC cell was saying. And again, the IPC cell seems to be coming in for some real criticism here. Did you find that in her testimony?
Yeah, very much so. As Nicola has said, she was clearly very prepared to give evidence, clearly relished the opportunity to be asked to give evidence on behalf of her colleagues, and she did so very well. And she painted a very good picture that many people won't have considered about just how tight an environment the back of an ambulance actually is, and how there aren't opportunities to ice or to distance yourself, for example. I think she said that the paramedics had the highest volume of sickness across the NHS, which again makes sense. So I suppose the big caveat to all of this, and it's not a failure on Tracy Nichols' part, is that it doesn't cover Northern Ireland. There will be similar lessons in Northern Ireland as well. I can think of, for example, issues with delays of ambulance, which she talked about in detail. One of our clients, Broudie McAvoy, lost her 23-year-old son, Connor. He had contracted COVID and condition deteriorated really rapidly. An ambulance was called, but due to the delay, they didn't make it in time. So as well as the IBC issues, there was significant delay issues and capacity issues, which I'm sure spread across the four nations.
One thing I learned from her testimony too, well, it's not that I learned it, but I hadn't really thought about it, is what a big machine it is. It was like they had problems with the shortage of 111 and 999 operators, which believe me, I personally know many people who could tell you that 111 simply didn't answer. And there was a shortage of ambulance vehicles. All these things, it's just this, if one cog goes, the rest of it goes. And your point that you made there, how she said they had the highest rate of sickness absence. And she said that was because of lack of appropriate respirators. Again, coming on from last week, this was a problem. And you said, I'm not sure I've understood, do you think there will be called a witness about the paramedic service, the ambulance service, specifically in Northern Ireland during this module?
It doesn't look like it. In fact, they won't be at this point. There is some written evidence, which is helpful to a point. We'll maybe touch on it a bit later, but the absence of data in general from Northern Ireland has been a theme across many witnesses. So the usefulness of an English witness or expert witness speaking about Northern Ireland issues is minimised because of an absence of data. So it would be much preferred if we had a witness from Northern Ireland with a lived experience giving evidence at the inquiry.
Was it Professor Adrian Edwards who talked about that lack of data from Northern Ireland?
Yeah, and a few others.
Should we move on to Northern Ireland since we have you, Enda? I wonder if we could talk about Sir Michael McBride, who's the Chief Medical Officer for Health in Northern Ireland. Can you tell us something about his testimony?
Yeah, sure. So this was the third time we've heard from Professor Michael McBride, who's the Northern Ireland Chief Medical Officer. And just to provide a bit of context, his role is very different from that of other UK CMOs. The main function of someone like Professor Chris Whitty, for example, is to provide independent advice to the government. And he's not embedded into any Department for Health or any NHS structures. Professor McBride's different. He straddles the dual roles of providing medical advice, but also as a senior figure with decision-making responsibility within the Department for Health, which we have previously pointed out is problematic in and of itself. In terms of his evidence to Module 3, the two main takeaways for me, which are related, was the discussion around DNA CPR, and related to that issue, the disconnect between those creating the guidance and those who are supposed to be implementing the guidance. The findings of an expert report from the inquiry was put to Professor McBride around DNA CPR, which said that variations in decision-making and conscious or subconscious application of clinical thresholds are likely to have occurred through the sheer complexity of circumstances inherent in the pandemic. In other words, there was an inappropriate application of DNA CPR. Peter Wilcock, Casey, for the Northern Ireland families, asked what steps the CMO could have taken himself to mitigate those risks. And Professor McBride's position was that he and his team not only developed guidance, but conducted workshops to ensure that the guidance was understood and properly implemented. He accepted that there were no investigations undertaken to investigate whether or not the disparity in the implementation of the guidance was correct. And he said that no specific concerns had been raised with him or his colleagues, and had they been, that he would have acted on it. at the heart of this discussion really is how healthcare in Northern Ireland is constituted. So he's saying that none of these issues were brought to his attention, and he's saying that the proper avenue, if a patient had an experience like this, would be to complain to their healthcare trust. So there are only 5 healthcare trusts in Northern Ireland, plus the ambulance trust. If that healthcare trust have a complaint about DNA CPR raised, then it should be up to them to speak to the Department for Health. So it's clear that that wasn't happening. And I think that speaks to the wider issue around the disconnect between those implementing or those creating the policy and those implementing it. Professor McBride's position was that he thought it was properly implemented. The problem is that we aren't really going to hear the other side. You know, we don't have the CEOs or clinicians from the trusts coming to give evidence about what their view was. Did they understand the guidance? Was it implemented across their hospitals? We'll have Catherine McDonald from Aldnagalvin Hospital coming to give evidence on Monday, and that might bridge that gap a little bit, but not in any significant or meaningful way, because the evidence is only for a short period of time. It's for one of Northern Ireland's best performing and best resourced hospitals. So I'm sure there are healthcare staff, you know, really keen to share the experience in some of the worst performing hospitals. You know, when we look at places like Craigavon or Causeway or Antrim, to name a few, as well as the bereaved families, you know, who have this lived experience of DNA CPR being misapplied. So that part was frustrating for me in many ways, albeit it was positive to hear a discussion around the issue, which hasn't been talked about a huge amount before Module 3.
I saw you nodding your head, Nicola, when Enda was speaking. Did you want to add something to that witness?
So one of the most striking bits of his evidence was really about a missed opportunity, in my view. So we know that the CMOs had this WhatsApp group that they were all members of. And on the 28th of January, the Northern Ireland CMO sent a message to the others saying that there was evidence consistent with asymptomatic transmission. And the response from Chris Whitty was that it was a possibility, but there wasn't evidence of it. And McBride says that he agreed and that he was raising that it was a possibility and that they should be alert to it, but that Whitty was saying we don't have any evidence of it. And this seems to me to be an indication that Whitty really was the power amongst the 4, and that if any of the others tried to raise something, if Whitty was dismissive of it, then it would just kind of go away. It didn't seem to me that McBride felt empowered to really challenge Whitty on that and say, well, hang on a minute, we can see that it looks to be happening. Don't you think we should be doing more to figure out whether it is? And if so, should we be changing our approach in terms of the precautionary approach? And that was something that was there at the 28th of January. And yet it wasn't until May that it really gets on the radar of nerve tag. So that's months and months and months of asymptomatic transmission going unheeded, really.
Yeah, and also on that point, Nicola, you know, if Professor McBride held that view, he didn't need the endorsement of Professor Whitty or anyone else really for Northern Ireland to take a different approach. I think if we cast our minds back to Module 2, it was really for political reasons that the paths did not diverge between the nations. So they relied very heavily. They mention it virtually every time we hear from them, the importance of this CMO WhatsApp group. But I think you're right. It may have helped in some respects, but that does seem like an opportunity missed.
Speaking of Chris Whitty, I wonder, I know we're going a little bit out of order in the order the witnesses appeared, but since we're talking about him, he was the last witness this week, and he spoke yesterday. And can I just say a little thing about that I've noticed reading about his testimony today, and this is kind of a sidebar. It's what we're up against with the press. I saw a headline saying that he said, oh, maybe we overdid it. I'm paraphrasing now. He says maybe we overreacted about the restrictions, but the full quote was, or maybe we underreacted. And yet I feel like we're being presented with this thing like, oh, it was too much, the precautions that were taken. It's just so frustrating for people like me, for the bereaved who are following these stories, to see things like that. And it continues to minimize what the whole pandemic was and what everyone went through.
I think I've seen the same headline as you. It's an incredibly misleading headline. It actually says, Whitty admits we overdid it. He said no such thing. This was in the context of the fact that during the first year of the pandemic, there was far fewer people coming forward in terms of heart attacks and diagnoses of diabetes or cancer. And that's because people weren't going to their GPs with concerns. And that's because either they were scared to go because they didn't want to come into contact with people who might have COVID, or because they didn't want to put any extra pressure on the services. And so they stayed away when really they should have gone to the GP and put themselves first. What Whitty was saying was, was the information that we put out, did that scare people off from looking after themselves? Did we get that balance right or wrong? And basically, we'll never know, because if we hadn't have done X, it might have resulted in Y. If we hadn't told people this is dangerous for certain groups of people, if we hadn't told people that anyone can catch it, if we haven't told people, whilst the young people are at lower risk, it's still a risk. And we know from the long COVID groups how many young people are suffering with long COVID. If we hadn't have told people that, would more people have died? Would more people be suffering with long COVID now? And just in relation to that article, all the comments in response were, see, always been saying this all along. I knew it was nothing but a flu. I'm sorry, you missed the evidence of Professor Fong in that case, because he was saying, for all those people who said this was nothing but flu, for all those people who called it a scandemic, hang your head in shame. That's the full evidence that came out yesterday.
It's incredibly frustrating. I'm sure you agree, Enda, about the way it's reported, and kind of the laziness of people who will grab onto those kind of headlines as evidence for whatever they are inclined to believe already.
Yeah, absolutely. And obviously what's most important is what the chair takes away from the evidence, but we can't get away from the public facing nature of the inquiry and the importance of that. So the media do have a responsibility to report accurately. The evidence was complex at times and hard to follow. I'm far from having a scientific background, so I was at times struggling myself and had to read over it afterwards. But one of the key takeaways, I thought, was the comments around ICU capacity, and it followed on from Professor Fong's evidence about the lack of capacity. So it was interesting to hear Whitty describe it as a political choice, which actually, when you think about it, it is. And that there is much less reserve in the UK than other comparable countries, and less so in Northern Ireland. Northern Ireland has ICU capacity, which is half of the European average. So the combination of Whitty and Fong's evidence was actually gave quite a big cause for concern, because if we have another health emergency, that capacity is going to be a huge factor, and it's something that has not been addressed.
And both those witnesses talked as well. It's not just the beds I think it was Professor Fong, we'll come to him in a minute, but he said, people seem to think an ICU bed is something you plug a patient into, not realizing it's staff. Chris Whitty said this yesterday too, the importance of having enough staff and training up those staff, and not concentrating so much on the mechanical side of it. Okay, there was one little thing that kind of annoyed me with Chris Whitty's evidence. I think we've seen that WHO, the World Health Organization, tweet. We've seen that now several times put up from 28 March 2020, where they said COVID is not airborne. And he, as some other witnesses, he was questioned about it. And what he said was, he was asked if he addressed this or showed any concern about this. And he said, no, because I don't think tweeting is a good medium. This annoyed me because tweets and social media, that is what many people read and believe and cite as evidence. And that's their only source often. So like, it just felt that perhaps the people in power were very out of touch with that kind of thing and don't realize the importance of having the WHO send that tweet out and how it will affect people.
The evidence about the tweet was maddening. Whitty has become very, very comfortable giving evidence and is far more combative now than he was in Module 1, for instance. And when it was put to him that this tweet from the WHO was a concern, and did he do anything about it? Did you raise it with WHO and get them to alter it or take it down or anything? And he kind of laughed in what I took to be quite a belittling manner and kind of said, it's really not my job to be policing tweets. And that, you know, if he took action over every single tweet that was wrong, then, you know, that would be a full-time job. No one's asking him to do that, but this was a tweet from the WHO that people look to for serious medical guidance and advice. This was something that he stated was too definitive, that he wasn't happy with, yet he did nothing to correct it. He belittled tweeting as a means of communication. But we know how tweets have the power to reach a far broader spectrum of society. Fewer people watch live TV nowadays than ever before. So you couldn't guarantee that everyone would be watching Whitty when he was on the latest press conference. And he really contradicted himself when later on he said that they did everything they could to reassure the public that the NHS, the GP practices were open, because he said one of the things they did was to tweet about it. So it's either a helpful medium or it's not. You can't pick and choose. And so I absolutely think he was duty bound to either raise it with the WHO or to put out a counter tweet that said, treat this with some caution. We're not quite there yet.
You said something interesting there, Nicola. You said how he seemed very comfortable, and talking to some of my fellow bereaved, that came up a lot. People said he seemed much more polished, much more comfortable. Did you find his testimony in this module and different from previous modules?
Yeah, I did actually, and it was a bit frustrating at times. You know, a lot of his answers are highly caveated, highly technical. It's hard to actually get to the solution that he's suggesting. And actually, Jack Carey, Casey, pressed him on that a couple of times, you know, to actually say, well, if this happened again, what would we do differently? And, you know, it was really hard to get to what recommendations he would make. At the end of it all, he did make a few useful comments at the end of his evidence about what would be more helpful in future. The mechanism to do research fast, do scientific research was a big thing for him. Another important point, I think, for the families as well is that the whole system should be more serious about tackling health inequalities between pandemics and reducing those vulnerabilities before they are exposed if another health emergency hits. So A bit of a mixed bag. I think the way he presents some of his evidence isn't entirely helpful. It's difficult to follow, but as I said, the important thing is that the chair and the inquiry understand it.
Thanks, Enda. I think there's no doubt that the witness this week who had the most impact. Last week, I think we all agree it was Dr. Barry Jones, and this week it was Professor Kevin Fong, who is a doctor and anesthetist. He's the former National Clinical Advisor in Emergency Preparedness, Resilience, and Response. And what he did during the pandemic was to visit ICU units. I think I've understood that, to see what it was like. I don't think any of us were prepared for the devastation of his evidence. And the way he presented it, I'm getting ahead of myself here, but I think for me, what was most moving was seeing a human being who had been indelibly marked by his experience. I'm getting emotional even talking about it, and changed, and by what he saw, by what he experienced. And he was understandably traumatized. And when I contrast this person, this man, with people who went off to the jungle to further their reality TV careers, who were happy to let the bodies pile high, it just got me. And I know a lot of the bereaved that I've been talking to and in our chat groups, they are unable to watch his testimony. They're afraid. And we've been recommending that people not be alone when they watch because of the power of it. And this is the power of truth, of the truth of what happened. And before I get much more emotional, I'm going to pass over to you. And
Wow, yeah, I mean, it was so powerful. He was clearly a man of huge integrity, of huge empathy, and someone who actually seen what was happening on the ground. Some of the quotes that to take away from the evidence are really impactful. He had said that a comment from one doctor was that it had been like a terrorist attack every day since this started, and we don't know when it's going to stop. Another one was that the first wave felt like everybody's war, and this wave, the second wave, felt like nobody's war. Speaking about the difference in staff mentality between the different waves of the pandemic. So yeah, look, the usefulness of his evidence cannot be overstated. And I think similarly for the usefulness of bereaved families' evidence, there's a parallel there, because Professor Fong was on the ground. He was able to see what was happening. He was working in a hospital and also visiting some of the worst hit hospitals. The bereaved families have lost loved ones within hospitals and have a real lived experience of what was going on at the time. So I think the key takeaway, and I hope the inquiry take this on board, is that evidence is so much more useful than hearing from someone who is still in the post that they held during the pandemic, is unlikely to give an unvarnished view of what happened. So look, more of this moving forward, I think, is what's needed.
I agree, Enda, and you're saying that. I think that's a lot of what we've been talking about too in our groups. This is the evidence we need, the evidentiary, not just impact, evidentiary evidence. And that's why we think we are still continue to be disappointed that the inquiry won't take direct testimony from the bereaved. Nicola, you were in the room with this incredible witness.
Yeah, I think the first thing to say is I'm sorry for how upsetting it is for you, Lorelei, but for all our other bereaved families who have listened and watched, it is incredibly distressing. And so I endorse what you say, Lorelei, about people taking caution, watching it with others, doing it in bite-sized chunks if that's what helps, anything. But it is incredibly powerful but incredibly important evidence. The second thing to say is we didn't know about Dr. Fong from anything that came to us via the inquiry. Actually, we suggested that the inquiry call him as a witness. And that was because one of our clients, a member of the group, Professor Naomi Fulop, had heard him speak. And she came to us and said, you need to get this guy to give evidence because what he's done is incredible. And so we suggested him to the inquiry. And so I'm glad that they listened and did call him. The third thing is to put his evidence in its context. So he's a clinician. He's one of those amazing people who not only works in the hospital, he volunteers in air ambulance. So he jumps out of air ambulances and rushes to save people, which, I just think is phenomenal. But he was emailed by a fellow clinician who basically said, this is how bad it is. You need to come and see it. Because it wasn't that bad at his own hospital. So he went to this colleague's hospital and was just completely shocked by the devastation that he saw. And he was shocked because this wasn't being recorded in the data. The data wasn't telling them how bad the pressures were across all hospitals. So if you work in one hospital where everything is fine, that's your experience. If you work in a hospital that's being devastated, you don't have time to fill in the lengthy data reports that are being fed back to government. So that data is being missed because it's not being collected. And so it was because of this one experience that he set up a program of peer support visits to other hospitals. He personally visited over 40 other hospitals with a group. And so his experience is not just of what he saw in his own hospital, but what he saw in at least 40 other hospitals. And if it wasn't for that, we wouldn't know just how bad it was. I mean, I say that because obviously all of the bereaved have seen things through their own eyes. But to actually hear it from a clinician talk, not just about the experience in their hospital, but across the board. And that's the bit that was missing. And he used this phrase a couple of times about the importance of, yes, data, but there was this gap in the data. And he said, not everything that counts can be counted, because there's an important qualitative data, not quantitative. Quantitative is just numbers. Qualitative is that anecdotal lived experience that wasn't being captured. And I'm so grateful to him for coming to give his evidence. And Enda and I were both there. We had clients who were in the hearing room and we had clients who were in the viewing room, and everyone was in tears. It was incredibly distressing, but everyone said how important it was that that evidence was heard, because they all knew it for themselves. But for some reason that wasn't being recognized. So to have a clinician tell that story, it seemed that more people would listen to that. And that's a terrible shame for the bereaved to not feel believed. But it does seem that in this instance, his evidence carried greater weight.
It did. I think the thing that was that moved so many of us as well was we've heard a lot of quite cool testimony. And I think the fact that he emphasized that there was a human element and a technical element, and that we're really good at all the technical side of things. And as you just said about counting what we count, Nicola, but the social element, how important it is, and how we have to look after these healthcare workers, because the horror stories of what they went through, I know some of these things are triggering, the things about them not knowing there was no vaccination, not knowing if who they were treating was going to kill them or their families, if they were going to take it home, that they ran out of body bags, that just the turnover of patients as people died. I mean, it was, I'm not sure even I had realized that till then. He also then moved on to the 4 things that he thought that he would recommend. Did you want to talk about that, Enda?
Yeah, so in contrast, perhaps to Sir Chris Whitty, the recommendations that Professor Fong put forward were very clear. And I think the most important one from my perspective was back to this issue of capacity. He said that so much hinged on capacity. And, again, to go back to Northern Ireland, when I look at Northern Ireland and the rest of the UK at the moment, it really gives me pause for thought, and should give everyone else pause for thought, that those systems have not improved, and that if another health emergency was to come about, that we would be in a as bad or potentially a worse position in relation to ICU capacity. So much flows from that issue of capacity. There was also an important point around operational memory, the importance of preserving operational memory for the health systems to bank the experience that they've had from COVID, and to, I suppose, I think what he was getting at is that's implemented into guidance and general practice moving forward. But that none of that's really possible without the system being properly resourced and funded. So I think there's a wider public importance, certainly I thought there was, to his evidence, because the pandemic, created this kind of an element of mistrust between the general public and potentially, healthcare services. I think people like Professor Fong helped to bridge that gap. They identify the issues that healthcare staff were facing through no fault of their own, and the knock-on impact that had on patients within the hospitals, and then by extension their families. So I hope that will be the lasting impression on the inquiry, the fact that the system needs to work in order for the healthcare staff to work properly, and in turn for patients to be treated properly.
Yes, I noticed, it did strike me, you just mentioned it, Enda, when he said organizational memory is short and it needs to be captured and resourced now. I kind of have a general question for both of you. I think that's a lot of us, I'll speak for myself. I just feel so frustrated because I do feel we're learning a lot from the inquiry. I do think it's incredibly useful in that way, if you have the will, you're willing to make the effort to follow it. But it's frustrating for me because I do not see any changes being implemented now. And I almost can't believe it. I think we've talked before about how I go into hospitals, nobody's wearing a mask, and all these, there are some things without changing the system or pumping a bunch more money into it could be done, I would think. And some of us just feel very frustrated because we don't know what to do with this, and what we could do to maybe help, or how we can encourage people in power to take some action now.
I think it's striking that one of the things we've heard time and time again, not just in this module, in previous modules as well, was that before the pandemic, the NHS was on its knees. And so when the pandemic hit, of course, it was overwhelmed. And Professor Fong made it clear that anyone suggesting that the NHS was not overwhelmed is wrong. And everyone agrees that we need to have more doctors and nurses in the system. And yet we are still hearing about doctors and nurses going on strike about pay. How else are you going to get more doctors and nurses wanting to do the job if there's daily disputes over the level of pay? These are people who we owe our lives to, and yet they are going to food banks. That just seems incredible to me. I think we have to get back to making working in the NHS an attractive career, not going into private practice, working for the NHS. And until that is considered an attractive career again, we are always going to struggle to have the number of ICU nurses that are needed to have a decent number of ICU beds. Because as we've said, a bed is not a bed is the staff to man that bed. And the number we are supposed to have is one nurse to one patient to properly look after that patient. And throughout the pandemic, that care was diluted in some places to as low as 1 to 6. So one nurse running around having to look after 6 patients. And Professor Fong was telling us about, the noise of hearing all these alarms going off when syringe drivers needed to be replaced or oxygen was running out. That is not a picture of an NHS that is coping. Anyone who says the NHS coped is just not in the real world, I'm afraid.
I think he did touch on that about how when people were saying it wasn't overwhelmed, we're looking at machines, items, and not the human cost.
Yeah, so look, I think that the sense of helplessness that was felt from, clinicians on the ground in hospitals that Professor Fong was speaking to, I think there's a real parallel with that in the general public. The idea that, that they didn't know how to resolve the problem. And I think from what we've heard through the inquiry is that the more systemic problems cannot be resolved without proper resourcing and proper funding for public services. In Northern Ireland, it's something that's on the news every night, whether it's healthcare, the environment, or something else. Public services aren't properly funded, and that is really the starting point. There are other things that can be done that don't require funding. One of the things from Professor Fong's evidence, which was very clear, is that lines of communication between those on the ground and those at decision-making level weren't strong enough. That's something that I feel can be straightforwardly implemented before the inquiry produces its report, although I hope that the inquiry picks up on that and makes recommendations on it as well, as this would definitely strengthen the argument for making those changes.
Thank you. Thank you both. I mean, the weeks seem to get tougher and tougher hearing some of this. And I know you must be paying a price for that too. I just wonder if there were any closing thoughts or anything we might have forgotten, Nicola.
I think it's just the lesson from Professor Fong, and it's just that line of not everything that counts can be counted. We need to take stock of the things that really matter, not stock of things like ventilator beds. So, as important as all of that is, we need to look after the people, because if we don't look after them, they can't look after us.
And
yeah, I think two points. One point of optimism, as Nicola's mentioned about Professor Fong. There's much to be learned from his evidence. I hope that it'll be picked up on, and that it'll form a significant part of the inquiry's recommendations for Module 3. The second point is a note of pessimism, really, in relation to the Northern Ireland evidence, and the question that we repeatedly seem to be asking is, what about Northern Ireland? We're hearing from some witnesses, they're generally at a high level, sort of corporate level. We're not hearing from enough people on the ground. That would really help to fill the gaps in our knowledge around, how Northern Ireland hospitals coped with the pandemic. We have the experience within the bereaved families group in Northern Ireland, but without the ability to share that, without the ability for on the ground healthcare professionals to share that in the inquiry, then I fear that we aren't capturing the full picture.
thank you both, as always, for coming on and for doing this. I know the podcast means a lot to so many people who are unable to attend the inquiry. So thank you both.
Thanks very much, Lorelei.
Thanks, guys.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.